May I now ask Tarun Jindal to take over and start the session on the next.
Thank you, and we had a very interactive and a very interesting session of small renal masses in the morning. Now we proceed towards another common problem of non-muscle invasive bladder cancer. So the pattern will be exactly the same as we did for the small renal masses. There will be presentations, and followed by that we will have voting. And for this session, let me invite Dr. Srivatsan, who's the coordinator of this session, and you can take the ball rolling from here. Thank you.
Thank you, Dr. Tarun. I think without much ado, we'll move on to the session. I request our chairpersons for this consensus statement for high-grade non-muscle invasive bladder cancer, Dr. Arnulf Stenzel, Dr. Ganesh Gopalakrishnan, and Dr. Lalicha to come to the dais, please. The voting will be taken care by Dr. Simon and Dr. Keval Patel. So we'll start with the first talk of the session. Request Dr. Jivitesh Goda to present his talk on optimal diagnostic imaging.
Where are the others?
Good afternoon, everyone. Today I will be talking about optimal imaging in bladder cancer with a slight more focus on non-muscle invasive bladder cancer, as that is the subset of discussion right now. So basically, role of imaging can be divided according to the T, N, and M stage. In T staging, usually it is a CT and a MRI for the local staging, and gold standard is considered the cystoscopy, especially in cases of non-muscle invasive bladder cancer. End staging, usually when local pelvic staging can be accurately done on MRI, and if you're doing metastatic evaluation, that can be done on CT as well as on PET CT for distant metastases. And for M stage, PET CT and CT are obviously considered the tests of choice. MRI will not suffice for that. So the question is, why image? Especially when you're dealing with non-muscle invasive bladder cancer, in which usually TURBT is the methodology of choice. So there are meta-analyses on this topic. As stated here, Nasili et al. Stated in their meta-analysis that up to 50% of cases with T1 tumors following TURBT can have residual tumors, which will require another TURBT. And other various studies have quoted percentages anywhere between 33 to 50%. So re-TURBTs and the chance of missing muscle invasive component due to inadequate retroducer component in the sampling can have bearing on the patient in terms of cost, delay in treatment, and discomfort. And another study by Lanati et al. Said that around 30% of cases fail to recognize muscle invasion due to lack of adequate detrusor muscle in the sample. And patients who are understaged, according to Datta et al., the 5-year mortality rate was 30% higher compared to those who were staged correctly. So definitely understaging at the initial presentation can have effect on the patient's life. So a study by During et al. Said that around 88.9% sensitivity and 91% specificity is there in muscle invasive bladder cancer on visual assessment cystoscopy. So, however, another study done recently by Christine et al. Showed that around the sensitivity was around 71.8% and 89.9%, which corresponded to a moderate degree of accuracy. So there was a discrepancy between the two studies which relied on the visual assessment of presence or absence of muscle invasive component on cystoscopy. And further, there are studies which say the possibility of micrometastasis due to the tumor handling, recutting of the tumor again and again for the sampling, which can lead to micrometastasis. So, data of 276 patients showed that there is overstaging of 8.3% patients, and higher rates of understaging are there up to 29.4%. when being evaluated on CECT. So obviously CT is not a modality of choice in that case when you're evaluating the bladder cancer locally, as it cannot differentiate very well the muscle invasive component. So next comes the PET-CT. It has a limited role in local staging because of accumulation of the FDG within the bladder, which can significantly obscure the local tumor. However, its true value lies in the distant metastasis detection, especially in nodal mets, in which it clearly outperforms CT, 78% versus 44% in picking up metastatic lymph nodes, especially the subcentimetric one, which can cause a lot of confusion. So contrast enhanced CT, usually the protocol is a plain scan, a urothelial scan done at 60 seconds after injection of contrast, and a 5-minute delayed excretory phase. And ideally a thorax and abdomen should be covered when PET-CT is not already there to account for any metastasis. Of course, this is I'm talking about when a suspicion of metastasis is there in the clinical setting. And another thing is that the tumor evaluation is usually done in the urothelial phase as opposed to the excretory phase. There is still some belief that the delayed phase, when the contrast has accumulated in the bladder, is somewhat optimal to look for tumors. That is not the case. There have been multiple studies which show that 70% versus 89.3% is the detection rate of tumors, especially the smaller ones. And this is an example here. We can see the bladder has completely filled up with the contrast, and you're not very well able to delineate where the tumor is, compared to a urothelial scan in which the tumor mass clearly enhances and you're more confident about the tumor's location. Same is the case with PET-CT. As I mentioned earlier, the accumulation of FDG can significantly obscure the local anatomy of the bladder. See, as you can see, there's a large mass here being completely obscured by the accumulation of FDG. It's at least a T3, could be a T4 disease as well, and completely obscured by the FDG. But its strength also lies in the detection of nodal metastasis, as I mentioned earlier. A post cystectomy case presented with new onset of very small nodes which could not be definitely characterized on CT. Another one in the left SCF, a very tiny node, again too small to characterize just on CT alone. But as you can see on the PET, there is an avid uptake of FDG in this, which leads to a strong belief that it is indeed a metastatic node. And compared to the one on the left SCF, which does not have any FDG activity at all. So you're more confident that the retrocrural node is metastatic, whereas the left SCF node is non-metastatic in this case. So now coming finally to the MRI, which is the focus here. Which is basically standardized on vesicle imaging reporting and data systems, or VIRADS. So the meta-analysis of 20 studies showed that the pool sensitivity of 92% and specificity of 88% is there in distinguishing between non-muscle invasive bladder cancers and muscle invasive bladder cancers on MRI. And this was basically a reporting data system formed by a multidisciplinary group of radiologists, urologists, pathologists, and radiation oncologists. It is a 5-point assessment scale to basically which stratifies the probability of a muscle invasive component being there in the tumor or not. So the imaging protocol which is recommended is, first of all, it should be at least a 1.5 Tesla machine and preferably a 3 Tesla machine. And patient should be asked to avoid 1 to 2 hours before the study, and during the 30-minute waiting period, he should drink at least 5 to 1000 ml of water. And a small T2 weighted image, a diffusion weighted image, T1 weighted image to see hemorrhage, and a dynamic contrast image, all are done as a part of the VIRADS protocol. I will get to the importance of each sequence as I go on. So basically, what can we see on an MRI when we're talking about bladder? So as we know, the T-staging is based upon the involvement of the urothelial layer, the lamina propria, the muscle layer, and the fat layer, and finally the adjacent organs. So as I mentioned, CT cannot clearly identify the muscle layer. However, the advantage lies here in that in MRI lies in the fact that it can identify the muscle layer, which is pointed by the yellow arrow, as a hypointense signal very well. However, the inner urothelial layer or the mucosa is not well differentiated. It can be in the earlier dynamic contrast phase, but that is not enough to stage it though. And some degree of difference in the signal intensity as seen here can be there if there is any inflammation in the bladder wall. So that always needs to be accounted for. As I mentioned, previously the T2 signal in a normal bladder was more hypointense, whereas in a diffusion it is more of a intermediate signal, which we radiologists call it as intermediate, which is a less bright signal. And this is the normal signal of a wall. So this is the 5-point scale which I mentioned earlier, which takes into account the T2, is hidden behind the timer here, T2 dynamic contrast and the diffusion. I'll get to it one by one. So this is a diagrammatic representation of the same. Basically the virides 1 and 2 deal with polypoidal tumors, or tumors which are virides 1 being tumors which are smaller than 1 centimeters, and virides 2 tumors which are more than 1 centimeter, with a stalk which has an intact urothelium which enhances, which I will demonstrate. Virides 3 would fall in the indeterminate category, where you're not very sure whether there's a muscle invasion present or not. And 4 and 5 would be definite muscle invasion, and 5 would be definite extension outside the bladder into the perivesical fat. So the first virides 1 category, which I mentioned as seen in the yellow arrow, is as seen in the yellow arrow, a T2 intermediate lesion. Behind it you can see the hypointense signal of the wall is quite well preserved, and even on the diffusion you can see the tumor shining out quite well compared to rest of the normal bladder wall. So this is a small tumor, smaller than 1 centimeter in size, and categorically it will fall under the virides 1 category. And this is a polypoidal tumor larger than 1 centimeter, so it is at least virides 2 looking at the T2 image. Now following that on the dynamic contrast image, as I mentioned earlier, there is a stalk which usually attaches to the urothelial wall, which has hyperemic and enhances more, which you can see here as marked by the yellow arrow. This marks the differentiation of the tumor from the muscle layer. So you are quite confident that there is no muscle invasion present in this case. So again, this would fall under virides 2. So the category 1 and 2, you're quite sure that there is no muscle invasion present. So for the same case, diffusion imaging, you can see the polypoidal lesion quite well, and behind that the wall signal preserved quite well on both on ADC and diffusion maps. Virides 3 again, you can see a broad-based mass which is not polypoidal. It is more broad-based, and the enhancement pattern you can see is slightly obscuring the wall of the normal bladder. So here you are not very confident. So it is better to call these lesions as virides 3, where the possibility of muscle invasion cannot be completely ruled out. Virides 4 would be definite interruption in the bladder wall normal T2 signal. As you can see here, the signal of the tumor clearly disrupts the normal T2 hypointense signal of the bladder wall. Same on the diffusion, the tumor shines out quite brightly on diffusion and interrupts the normal lower intensity bladder wall signal. A similar case again are virides 4 clearly interrupting the normal wall, which is here, and this is the mass which is clearly interrupting the wall, a muscle invasive mass. So another case of virides 5, where there is an outgrowth of the tumor into the perivesical space, or the clear extension of tumor into the perivesical space, where tumor infiltration into fat is there. So another similar case of virides 5, definite infiltration of the tumor mass into the perivesical, and T4 disease because it's infiltrating into the pelvic side wall and even the rectum. Another case in which CT there is diffuse thickening of the bladder following TURBT of a non-muscle invasive lesion. So the degree of suspicion for such a diffuse mass is anyway low, but this can be confusing, and on MRI you can see the hypointense signal of the bladder is well preserved and there is no diffusion restriction. So you're quite confident that there is no suspicious mass, and the bright inner layer you're seeing is the urothelial layer. So you're quite confident that the tumor is not present there. And this patient was followed up, given some antibiotics, kept under surveillance, and gradually this inflammation resolved, which was nothing but inflammation in the bladder wall. These are tie-breaking rules where diffusion and contrast can be used to differentiate when there is a confusion in which category to put the lesion. And validation is there for this study because there is a high diagnostic accuracy in differentiating between muscle invasive and non-muscle invasive components, and there have been meta-analysis which showed that if you keep VIRADS 3 as the cutoff for considering it as a muscle invasive tumor, you can achieve a specificity of 86% and a diagnostic accuracy of 93% when you call it a muscle invasive tumor. And as you can see, the inter-reader agreement ranges from 0.73 to 0.92, which show that it is a reproducible technique and you will not go wrong with it. So the future is that it is designed for treatment-naive patient, but in practical settings, a lot of these patients come for imaging after having undergone TURBT once. So that is still an ongoing area of research. And the bladder path trial, which is going on in UK, is a randomized control trial, which is assessing the MRI, if MRI can accurately pick up the muscle invasive bladder cancer. And it is when compared with the cystoscopy directed TURBT. So surveillance with MRI and following treatment therapies with chemo and BCG and VIRAD score following the chemotherapy is another area of interest here. So conclusion, VIRADS is an accurate and reproducible imaging technique to differentiate NMIBC from MIBC and can be possibly incorporated into prediction models as well. Thank you.
I think we'll have questions after the voting or at the end of the session. For the lack of time, let's proceed to the voting for this part of the diagnostic imaging. Please, Dr. Sai.
Thank you. So we need to make sure everyone's turned your voting pads on again. It's the little red button, I believe, isn't it? So we've got 6 questions to go through, or 6 statements to go through here, and we'll rattle through them nice and quickly. So first one, optical enhancement techniques, so blue light, narrow band, spectra, should be used to guide all TURBTs. Excellent. And next question. So the same optical enhancement techniques should be used to guide a TURBT if new and multifocal disease. And next question. So back to optical enhancement techniques again. They should be used to guide a TURBT if there's recurrent and multifocal disease. And statement number 4 is an MRI and pinch biopsy can replace a formal TURBT for diagnosing suspected non-muscle invasive bladder cancer. Statement 5. Patients diagnosed with high-grade non-muscle invasive bladder cancer should have a CT chest to complete their staging. And the final statement in this section, patients diagnosed with high-grade non-muscle invasive bladder cancer should have an FDG PET-CT to complete their staging. Thank you. Back to you.
Thank you, sir. So we move on to the next topic. I call upon Dr. V. Chandramohan from Hyderabad to speak on optimal TURBT. They have a important question.
You are opening? Third. Respected chairpersons, seniors and my dear colleagues, I first of all thank the Global Uro-Onco team for please enlarge Global Uro-Onco team for giving this opportunity. Optimal TURBT, can you enlarge the screen please? Yeah. Optimal TURBT, see this topic should be told to all the PGs when they first take up the resectoscope and go inside the bladder to do TURBT. This is more useful for them, first year or second year or third year, because even in private practice when you do a large tumor or multiple tumors, we cut everything and put it in one box and show to the patient attendants that we have removed this much. What are all the tumors you have resected, all will come in one box. That is wrong. That exactly this tells. You should have mapping like the way we do sextant biopsy, extended biopsy in radical prostatectomy standardized. This is still in the, it should be done like this. That is the aim. And second thing is, this cancer is dreadful, and even after doing radical cystectomy, lot of the patients die within 5 years. Probably some mistake is done by the surgeon also. That also will be covered in this topic. So, complete resection of all visible tumors, properly following pre-op, intra-op and post-op is the aim of this talk. There is no doubt artificial intelligence, even if it comes after 100 years, we have to put your finger into it, otherwise you will put your foot into it. That is per rectal examination, bimanual palpation. That too under general anesthesia. You will definitely get some clue where it is invading. And visual inspection of all urothelium. Most important is we directly go to bladder neck and then sometimes we miss the urethra, normal urethra, not only prostatic urethra, normal urethra also. Of course, as a surgeon, we have to resect. What happens after some bleeding initial, we do fast resection and we do coagulation. That is not correct. If the muscle is not included in the specimen, it is not good TURBT, not lamina propria, proper muscularis propria. Then diagram and mapping, this is very important. Then NBA and fluorescent, some may have it, may not have this facility. Then post-op intravesical treatment. All these are strong recommendations. There is no doubt about it that examination investigations, I need not mention. This is also checklist. When you go, you never know, you use bipolar TURP, sometimes saline TURP, sometimes laser enucleation, normal water also can be used. But you should be mentally prepared. If by chance stricture urethra is there, you should have Otis also, you should have OIU also. Suddenly stricture urethra will come, you can't postpone the case because it is done spinal or GA. It is up to your choice. Then initial evaluation, whenever you say examination, symptoms, hematuria, evaluation, everything is important. Nowadays, everybody is using not only ultrasound, CT, IVU, urography. You should not miss the ureters. We are in the era of flexible ureteroscopy to detect the small tumors. So be careful about the urothelium. A good quality high CT called HRCT is CT is essential contrast CT, where they will take the urogram phase also, not to miss the kidney and the ureter tumors. I mean urothelial tumors. So all these are strong indications. One more important is this: whenever multiple tumors are there, I will show where 30 tumors were 32 tumors. 2 months back I have done cystoscopy. In 2 months, 32 tumors have appeared. But you should do ultrasound, say to the patient, what should I do? Should I resect all, or should I go for radical cystectomy, or large one what, small one what? If you don't tell, if you don't resect, he will say, I don't want radical cystectomy. That I will show. Goal of the TURBT is number of tumors, size, multifocality, characteristics. Many people, by looking at the tumor after experience, you can say with calcifications, stone-like thing, high vascularity, broad base, large tumor. Usually, if you manage conservatively, it is risky. I don't say they are not superficial, but apart from CT or MRI findings, look also matter a lot. Then I already said bimanual examination. Adequacy of resection. If in en bloc resection, which is my favorite now, that's why actually I am presenting today, I can perforate precisely up to the prevesical space and to send the specimen. Nothing will happen because there is no obturator jerk, there is no bleeding, especially if you use any laser, TFL or this thing. And chunk if you send, when you cut the pieces, muscle will be seen like a bundle, big bundle. They can easily comment. That is what the aim of TURBT, and all tumors. If one tumor is invasive, then entire management will change. So if you do incompleteness, what is incompleteness is if you cannot get the muscle, you have to go for relook TURBT. If you get the muscle also, sometimes you have to go relook if you want to go for conservative management. That is where the technique of TURBT, I am not going into the detail, everybody knows. Only thing is piecemeal resection versus en bloc, piecemeal monopolar, bipolar, most of the people bipolar doing. But I must tell you, even in bipolar, obturator jerk comes. We have seen many cases. Don't be over this thing confident, it will come. Some say that company is good, this company. Both companies have used jerk will come. So obturator nerve block also is essential. In en bloc it will never come. You will do in distended bladder because the heat is the energy, not the electricity. It is a very safe, but the only problem is you don't accept, many of you, that how you take it out. At least apply for 3 centimeter tumor. Baad mein we can say how to take out 5 centimeter. We can easily take it out. 5 live workshops we have done where superficial part resected and deep part, thick part, hold with a thick loop, come out and give to the specimen. Nicely this will come. Whether you reject horizontally or vertically, better when you see the bladder curvature. When you reach the flat of the curvature, stay back, remove all the fragments, send them separately. Now you take fresh, because once you cut it, you don't know which piece is what. Your eyes cannot detect it. So first all the superficial take it out, then deep parts 2-3 separate, with holding the loop only you take it out, put it in separate. You have to send 20 to 30 pieces. Each one will cost 400 rupees. Patient should be ready to accept, because pathologist, if you send 100 in one, take only 400 rupees. But if you take 20 separate, he will take 400 into 20 pieces. That means if you send in one dabba, it is of no use. So instruments, I am not going, flexible cystoscopy has come way digital. So there is no need for 70 degree and 120 degree. You can see your back. That means some bladder neck, which are areas which cannot be seen, easily you can see. The rest of the equipment is normal. These are all normal. Sorry, I am going back actually. So loop, thin loop, thick loop, both you keep. Thin loop nicely cuts, but it bleeds, no problem. Fronts you cut with thin loop, whereas the thick loop for coagulation. Side of the loop is for coagulation, center of the loop is for the cutting. But if you keep 2 loops, it makes a very beautiful layers will come out. From the bladder, one layer will come out. Obturator nerve block, I must tell you, one of my urologist wife is anesthetist, she comes. Obturator nerve we see so nicely, in radical cystectomy, we do lymph node dissection, but we don't know what happens after it exits from the obturator foramina. Suddenly you don't know where it comes here. Everybody is afraid where you femoral nerve, femoral artery. It comes nicely between the muscles. 3 muscles are nicely seen. If you really put a needle, it is superficial high frequency ultrasound. Just go there and infiltrate. Patient cannot adduct the limb also. Even without spinal anesthesia, if you give, it is very good. But only thing is that anesthetists are more experienced. We are not experienced. This is the way it comes between the adductor magnus longus 1 unit and adductor magnus 1 unit, adductor longus and brevis another unit. These two between plane will be there. This is actually the video. You can very clearly see the needle between the 2 muscles and 3rd muscle. 2 muscles and 3rd muscle. There you stop and it swells like anything. So it's a high frequency superficial ultrasound. Surgical approach is bimanual palpation. See the videos which 3-4 videos I will show. See, this is all after Jailocan jelly full it becomes red. When you are doing under anesthesia, Jailocan jelly has no use. Unnecessarily we put full Jailocan jelly. That is for local anesthesia. Otherwise entire thing becomes red. And even in bladder, Jailocan jelly will be floating. You may miss. Already these scopes are half used. Half of the scope only red, everything will be red. So you will miss the tumor. So you should be first focus properly. High definition camera should be there. Don't put Jailocan jelly more. Slowly go into the bladder and inspect the urethra. Then see this tumor, inspection of the whole urothelial epithelium. If you see suddenly if you see tumor, you will forget everything and start resecting it. And we will forget cystoscopy. It happens in the busy practice when 10 cases are there, lagao, then you resect, and then suddenly you should shook orifices for 5 minutes after giving IV fluids, whether the urine is this thing coming. So all these, especially bladder collapse, medium distension, pressing of the anterior abdominal wall also is an art. If you press suprapubic region, it will not come down. You have to go above suprapubic region and press downward. Then only the dome as well as the anterior part will come. Just suprapubic it may not come. Complete collapse with 0 water you should do. In fact, TURBT, always remove the pieces, again go back. Remove the pieces, again go back. Completely in a collapsed bladder only you start inspecting and resecting. Now, resection of this small bladder tumor monopolar. See, it is a very flat tumor. If you do with monoplonar, these flat tumors, what happens is, see here I am cutting very nicely, slice, but you will not get information about the muscle. You have to take a deep, this is the waste, it's like coagulating. So if you coagulate surface, you are not doing good job. Whatever it may be, you have to resect properly because it is very, it is almost, I am cutting over the ureteric orifice. Nothing will happen. If you coagulate only, something will happen. Unless you know that area has tumor, then you have to do flexible uteroscopy for this patient to say something about coincidental tumors. Now coming to the large tumor, what will you do? Patient says that I want muscle invasive proof. Doctor says that I may not be able to. Such a big tumor, if the muscle doesn't come, your purpose will serve. So you have to systematically resect, or one corner you have to resect so that the muscle is included, and that piece you have to take out separately. That means whatever the superficial pieces, you evacuate with the leaks and then go for it. So I am showing this, it takes lot of time in this because lot of bleeding will be there. It is not easy. See, total bladder is filled with, you have to collapse and you have to follow the curvature always. Otherwise you will go out and you may perforate also. See, what you are seeing, half of the time blood only you are seeing. In the last when you coagulate, you will nicely see. That time you take the biopsy. Definitely muscle will come. Not during the France taking. This is optimal TURBT. Like this, it's flat, now completely flat. Now you take from the edge properly deep biopsy. Very rarely it will perforate in a mediumly collapsed bladder. See, I have kept like this. It is of no use. What histologist will show? Even I am feeling sometimes I have done mistake. At least from today I will not do again. So next, resection of the tumor, bipolar, nothing great. Bipolar is nothing, just it is saline water, not much useful in TURBT because fluid overload is not a big problem. So there is no craze about bipolar TURBT, only light beautiful arc will be coming and you will be cutting. Otherwise there is no use, I must say. This is the 32 bladder tumors. First this patient has come, one tumor was there, we have resected, it has come high grade, non-invasive, we have done BCG, not responded, then he last follow-up, he came and suddenly if you have gone, I told 3 tumors are there, CT done, that is my luck. Then I said that if you don't, he says I don't want radical cystectomy, he is not mentally prepared. Then I have to reject. The moment I have seen 32 tumors, I was stunned. Then I called the attendant first inside and showed the tumors at least. So nearly 15 attendants were there outside. And this patient, one bladder tumor big is there at the prostatic urethra. That has taken away optimism for me. A very big tumor at the anterior neck. This small, no problem. See, one cut they will come. You cannot do en bloc here. So all the 32 I have rejected. All the 32 I have separated. But only problem is bladder neck region, large mass, looks invasive. And that tumor has come now non-invasive in the histopathology. Now I am struck. And he says that please get the specimen. They are in Bombay. Now the specimen has to come and they have to comment again. That means patients are educated. If you don't give the muzzle invasiveness or muzzle, they will definitely go to second opinion. That means optimal TURBT you have to know completely. That is the aim of this thing. So all tumors rejecting, I was doubtful whether half of the bladder mucosa I am peeling off, how it grows. More than half bladder mucosa except ureteric orifices, everywhere tumor is there. Within 2 months of last cystoscopy, that sometimes patient blames that you have not detected that time. But 32 tumors, how we will miss? So every case, every time you go in, it is separate. Now coming to the en bloc. This is my favorite. I am using for last up to 5 centimeter I do en bloc. It is very because in distended bladder you do it. The moment you distend, bladder becomes 2 mm. The moment bladder becomes 2 mm, within 1 minute you will perforate the bladder. But that perforation is controlled perforation. Controlled perforation means you can say that I am in this layer of pre-vesical fat, take out that small piece and give to the pathologist without any fronds, dissection, everything. And you can dome, you can nice like pencil you can cut. Even anterior wall you can cut. Only problem is large tumors cannot be cut, but it takes time. It removes lot of mucosa and it goes very deep invariably because you do in full distance. Is it for me, sir? Yeah. Well, okay. I have finished. This is multiple bladder tumors. Last slide. These multiple bladder tumors, 5-7 were there. Out of enthusiasm, I attempted all. I don't want to show all the rejections. At the end, you see small everything I have rejected. This is the last part. If you stay more time in TFL, it causes coagulation, but that is 0.15 coagulation. 100% all tumors we got the muzzle. Even 5 live workshops, we have taken out the entire muzzle. This is the ureteric orifice. I am just poking it. See, these are the 5-7 tumors. All are rejected with this thing. The only thing is that they have to take now separately and put it separately. That's all about the practical. Biopsy of the prostate is theory. You know what are the indications. Cold cup biopsy is also essential. All the mapping is essential. And specimen of pathology should be informed that this should be done. Narrowbanding imaging is only light is focused at different bandwidths so that you can see. In Olympus and STAR they have come now, you can see better. Now blue light I didn't know much because I don't have. This HLA will be injected into the bladder, blue light will be projected, it looks like pink, not blue. Blue is normal, pink is abnormal. To conclude, TURBT is the most important initial step in bladder tumor patients. Following the principles of TURBT allows to perform safe resection. Thank you once again for giving me this opportunity.
We'll move on to the voting session currently. So,
thank you. So we've got 10 statements here. They're not all about TURBT. We couldn't fit them in elsewhere. So keep your wits about you. But we'll start off with statement number 1. En bloc resection of the bladder tumour should be attempted at TURBT. Okay, so we move on to the next question, which will be interesting to see the response to this. Fractionated resection technique should be employed at TURBT. And next statement. The goal of TURBT should be to identify muscle in the resection specimen. Statement number 4. A single dose of intravesical chemotherapy should be delivered following resection of a new non-muscle invasive bladder cancer. So a single dose of intravesical chemo following resection of a new non-muscle invasive bladder cancer. Now, statement 5 is a little different. So we've got various intravesical chemotherapies here. So what's the preferred intravesical chemotherapy following resection of a new non-muscle invasive bladder cancer? Conclusive. So statement 6, in the context of a normal cystoscopy in CT-IVU, a positive urine cytology should be investigated with mapping bladder biopsies. Next statement, so a similar situation again. In the context of a normal cystoscopy in CT-IVU, a positive urine cytology should also be investigated with bilateral ureteric washings. And statement 8, again in the context of a normal cystoscopy in CT-IVU, a positive urine cytology should be investigated with prostatic urethral biopsies in men. And statement 9, random biopsies should be undertaken for all patients with a new bladder cancer to exclude carcinoma in situ. And the final statement in this section, which needed a spell check, prostatic urethral biopsies should be taken in all patients suspected of requiring radical cystectomy or cystoprostatectomy prior to consideration of orthotopic neobladder formation. Thank you.
So we move on to the next part of the superficial bladder cancer. So I invite upon Dr. Santosh sir to speak on the first line intravesical therapy, BCG versus other agents.
Good afternoon. Can I have the presentation fast, please? Okay. So we are running short of time, and then I have been asked to reduce every talk by a few minutes so that we can do. I have 60 slides and I'll be rushing through. There's a lot of literature to present. Thank Chandramohan for waking a few people with those videos, and I'll be going very fast. The good thing is I think all the data you know, so I don't have to spend time on it. I hope you'll get something new. So we know that superficial bladder cancers are 70%, and then they recur so fast, so there's something more than just resection to be done, and that's the reason why we need chemotherapy in some form, either single dose maintenance or immunotherapy in the form of BCG. The risk calculator, too complex to use in everyday practice, so nobody uses. Indians are very good at mugging up things, remembering things, but this is just too complex to remember, so nobody puts it down. Intravesical chemotherapy, a lot of drugs have been used for a long time, from silver nitrate to other things, very toxic initially, now sort of settled. Questions are what drug, how much, when, and how long. So that is the group of drugs that you see, and the various doses of the drug. The most common we use is mitomycin C, 40 milligram, 40 ml, or gemcitabine for those who have moved forward, 2 grams and 100 ml. So drugs and dosages, there's not much to actually in the literature to suggest which drug and what dose to use. So if you're using 40 milligrams and mitomycin C in 40 ml, that's fine. If you're using gemcitabine, that's fine. Little bit less, more, doesn't matter. If you spill a little few drops here and there, doesn't matter. Immediate instillation, I think, is a must in all superficial. It helps by destroying circulating tumor cells and also has ablative effect on the residual tumors. And it reduces the 5-year recurrence rate by 14%. Not a great, but yes, from 45 to 59 to 45. The drugs that are used are mainly mitomycin C. In most cases, gemcitabine can be used. The initial study of gemcitabine was negative. So initially there was that you should not use gemcitabine. However, there were problems with that trial, and it was proved that you can use gemcitabine, so don't be worried. Single instillation reduces the recurrence rate, has no effect on progression. So you need to remember that. Who benefits? Unlike what most people think and so religiously give, it benefits a few. It benefits only those with primary tumors, intermediate risk tumors with less than 1 recurrence in a year, and a EORTC risk of recurrence score of less than 5. So though we put it on non-muscle invasive tumors when possible, it benefits very few. We have extended the same thing for nephrectomy. It's part of the guideline for nephrectomy, when to put it after catheter, during the time of catheter removal. That's the time when you need to put it. Whether you should extend the same to doing when you do URS, you can do it, but there is no level of evidence as of now to support it. So I think with that we'll finish with the single installation, go on to maintenance. So question is additional chemotherapy recommended? If so, how long, how much to give? Immediately or little delayed? If you already planned for long term, why did you give single installation? So we'll try to answer those questions. We definitely need to give it. There is a definite decrease in incidence. So immediate or delayed, so there is no clear-cut answer to whether you should give it immediately or delayed by 1 week or 2. So if already planned for long-term therapy, can single installation be avoided? Answer is safely yes. You can avoid single installation, but most of the time you would have given it already. You want to make a protocol which works in your theatre, so all non-muscle invasive, let it go. Maintenance. A systemic review, 16 studies, mitomycin and other agents are used, intermediate, high risk. Dosing schedule, short, intermediate and long term depending on the time. Just be careful, this is only chemotherapy, not on BCG. So I'm going to jump very fast. 7 trials, epirubicin, doxorubicin, 4 trials, mitomycin C, 6 trials. This is on maintenance of chemotherapy, and the conclusion is that there is very little data. Most of the trials do not show any benefit of maintenance chemotherapy, and some trials show some benefit, and you cannot give BCG. You may think of giving it, whether it helps or not, data is not very clear. So mitomycin versus BCG, so intermediate versus high risk, meta-analysis of 9 trials, median follow-up 4.3 years, 43%, there was not much interest. So unlike what we think that mitomycin C may be very inferior to BCG, okay, in very high risk disease, if you have this thing, carcinoma in situ, it may work, but otherwise, if you're giving only induction chemotherapy, it may, if you're giving only induction BCG, it may be the same effect as mitomycin. So there's no great difference. So now let's come to the BCG, which is the mainstay of treatment. So BCG has been there for a long time, 1882, but only in 1972 or 76 it came in for bladder cancer, and the latest research is more on coronavirus, whether it reduces incidence of death in coronavirus. So you should know BCG, what we use has been different with times, the change thing. What we had in India was a Danish 1331 strain, which has been changed to the Moscow strain, being marketed by Cipla and Onco BCG, and being manufactured by SSI Serum Institute. They prefer to manufacture corona vaccines, and we were also short of the BCG vaccine for a while. So though so many strains are there, about 20 of them, but only 5 strains are the ones which are mainly used. So this is the Sentinel paper. There was initially scarification. However, the scarification was decreased, and what we realized was there was a 12-fold decrease in recurrence rate. And the same thing was again by Donald Lamb in his paper with the bigger numbers, proved that intravesical BCG reduces recurrence. What is interesting is even the initial paper, you see, out of the 18 patients who had BCG, nearly all of them had dysuria, and most of them had frequency. So that is something which you nearly expect in every patient. So if it is there, it is supposed to be there, so that has to be counseled. Fever luckily is in about 20-30 patients, that's where you need to get worried. BCG strains efficacy, there's only one study comparing the TICE with the CANOT. The CANOT was the older one and the TICE is the newer one, and they found that the CANOT strain had a greater recurrence-free survival than the TICE. This is just one study anyway. CANOT, I think, is not available. So this is, I think, ANN artificial neuronal network analysis comparing all the strains of available literature across different studies. Not much differences there, so nothing to worry. What is there, you use. So maintenance, this is the SWOG study. I think Harry very clearly showed that maintenance makes a difference. So everybody should get maintenance, intermediate and high risk patients. The maintenance schedule that they said was 3 weekly maintenance at 3-6 months. I think everybody uses that. Very important, the last line there, only 16% received all the scheduled maintenance dose, so should not be. Actually, in the discussion, Harry writes that because they had a strict thing that they stopped the BCG the moment patient had complications. So that is the reason why he said that probably efficacy is good, and they could not study the side effects that much because it was only stopped in everybody who had a complication. So there you see the results in more detail about that study, and then there was a meta-analysis by Maelstrom, which is very clear. If you don't give maintenance, you're as good as mitomycin alone. Induction alone. If you give mitomycin, becomes equal to induction. But if you give a maintenance, then you reduce it further over time. So 25 trials later showing there is a risk of reduction, 40% instead of 49%. And progression, again, there are 3 meta-analyses. Most commonly believed with 27% reduction risk. One of the meta-analyses showed that there was no reduction in risk of progression. Complications, let's concentrate a little bit. Mostly you will have local complications. Fevers are rare, about 20 to 30%. They are the patients in whom you should worry. And then if you have fever more than 48 hours, you need to start ATT or some form of treatment. Otherwise, if you have a traumatic installation, BCGitis systematic, you may lose the patient also. BCG shortage, everybody has had their BCG shortage. We too, during the corona time, had a shortage of the BCG. Internationally, it was because the Shanghai Pasteur strain had shut down the BCG production. The CANOT strain was stopped worldwide, and Merck was producing the TICE strain. In India, actually, in January 16, 2008, because of bad pharmaceutical practices, the Guindy lab was closed, which was giving BCG at, I think, 30-40 rupees for 40 milligrams. It was so cheap, but it was not maintained at a good quality, so they had to shut the lab. I actually checked the lab recently. They have appointed a director. He's been working till 2016, 2019. They got the production, and he writes in his vision that he will start the BCG for the intravesical BCG. So hopefully we will get, I don't know whether we'll get the Cannot or Moscow or what strain, or we will get the Danish 1331 back. But their vision, at least in the Guindy lab, is to start production for BCG, and hopefully it will be cheaper. Reduction of induction. Now, when there is shortage, people thought whether we should reduce, but more than that, I think in India we had a feeling that side effects are more and we should reduce, and been few papers from few institutions. I have not gone into details of that, but this is basically a study giving the idea that you could reduce the induction. Instead of 6 doses, give 4 doses, and their thing was that anybody who had BCG exposure, in 4 doses itself, you get enough immune response. But if you have not had, then you'll have to have 6 doses. Reduction in maintenance dose, lots of institutions still monthly dose for 12 months have been using as a maintenance. However, there is enough evidence in literature suggesting that this is not better than giving induction alone. So if you're practicing this, I think that practice has to be stopped. That could be one take-home message from here. Reduction in doses. So there is a lot of issue with reduction in doses. Though in literature some places say up to 1/3 you can reduce the doses, but whatever studies have been done on reduction of doses, we should know, are in the West. All the doses suggest that reduction of doses neither reduces the side effects, nor, and it definitely reduces the frequency, does not decrease the recurrence rate. So EORTC GU trial was the one, it had 4 arms and it reduced the dose 1/3 and also the 1 year versus 3 years. So there were 4 arms, and they found that there was no difference in the toxicity between the 1/3 dose and full dose, and only in the intermediate risk group 1 year maintenance was okay. In the high risk group we needed 3 years maintenance. So this is actually what is being followed now based on this study. The Kyoto study was again another one which is actually a negative study, once a week for 6 weeks and no maintenance arm versus 3 months for 3 years. So they tried to reduce the frequency of BCG, and they could not find any difference. So they could not reduce the recurrence rates. So again, they suggested that probably we are giving only once in 3 months. If we could have given 2 doses in 3 months, probably we would have got a better effect. That was their discussion in the discussion. Based on that, probably they did the Nimbus, where they did 3 doses for induction and then 2 doses for the maintenance at 3, 6 and 12 months. So this is probably from one of the suggestions from the Kyoto trial. However, this had to be stopped because they felt that they were, in the interim analysis, they were harming patients. So neoadjuvant is something which is again not investigated. It has been given and they realized that the results were better. However, when they did studies, there were contradictory results. So this is this thing. You give neoadjuvant first and then TURBT. So this is the investigational strategy. The second is chemoresection. The schedule is different. Mitomycin C 3 times a week you give for 2 weeks. And they realized that there was complete response in some patients. And so there's again varying results because the recurrence-free survival at 1 year was worse in these patients with chemoresection rather than TUR. So again, we need to figure out where this can work and where we can use it. There are newer strategies. So let's come to the take-home messages. Single instillation reduces recurrence in a select group, not in everybody as you may think. There is little evidence that maintenance chemotherapy helps. Chemotherapy maintenance does not help. There's very little evidence. BCG induction maintenance is the mainstay of therapy. 1 year for intermediate risk, 2 to 3 years for high risk. Reducing dose and frequency of BCG can harm. So very trigger happy to reduce dose frequency without much evidence. Okay, it's very dangerous, so you have to be careful about that. Neoadjuvant chemotherapy and chemoresection strategies need further exploration. As of now, it's not very clear. You may find out indications where they may work for you. Thank you. I think I finished only 45 seconds before time. Sorry.
Thank you so much. We'll go for the voting part of it for the intravesical first part.
Okay, so we've got a bumper session of statements here. We've got 12 to get through. Okay, this is the biggest group of statements. So I'll wait for it to come up on the screen. Do you want me to find it? Okay, statement number 1. Maintenance intravesical BCG therapy should be continued in total in all high-risk non-metastatic bladder cancer patients seeking bladder preservation. Statement number 2. Dose-reduced maintenance intravesical BCG therapy can replace full-dose BCG therapy in patients with high-risk non-muscle invasive bladder cancer seeking bladder preservation. Thank you. Statement 3. If BCG is unavailable or in the presence of significant BCG-related toxicity, primary cystectomy should be offered to all patients with high-risk non-muscle invasive bladder cancer. And statement 4, if BCG is unavailable or in the presence of significant BCG-related toxicity, intravesical gemcitabine chemotherapy can be offered to patients with high-risk non-muscle invasive bladder cancer seeking bladder preservation. And statement 5 is exactly the same, but instead we're suggesting intravesical doxorubicin chemotherapy can be offered. And statement 6, again, is the same, but this time is intravesical docetaxel chemotherapy. And statement 7, same scenario one more time, but this time is intravesical gemcitabine and docetaxel chemotherapy combined. Statement 8. So if BCG is unavailable or in the presence of significant BCG-related toxicity, radical radiotherapy can be offered to patients with high-risk non-muscle invasive bladder cancer seeking bladder preservation. Statement 9, same scenario again, but this time intravesical mitomycin C hypothermia. It's also known as Synergo. Can that be offered to patients seeking bladder preservation? And statement 10, same scenario again, but this time systemic immunotherapy with pembrolizumab. Can that be offered to patients in the first line? Statement 11, concomitant steroids should be prescribed for patients with BCG cystitis to improve tolerance and reduce symptoms, to improve their compliance. And the final statement in this section, statement 12, fluoroquinolone administration should be avoided in patients receiving intravesical BCG therapy. Thank you.
So we go to the final talk of this first part of non-muscle invasive. I call upon Dr. Giridhar Bora to talk on intravesical therapy for high-grade recurrence.
My slides, please. Good afternoon. Thank you, Dr. Ghosh, Dr. Ravi, for this opportunity. And I'll be taking the case of intravesical therapy further for NMIBC. Here, the patient is already recurred with a high-grade tumor from a primary after a first line intravesical therapy. So I'll be discussing what are the other intravesical options once the patient fails from the first line intravesical therapy. Now, if the patient fails after first primary intravesical chemotherapy, then the patient should be offered a BCG installation, because a primary chemotherapy in a first line setting has no impact on the effect of BCG. However, if the patient has already received BCG as a first line management, now we have to understand various BCG failure categories in these patients. The first is BCG refractory tumor. If you have done a TURBT, given a BCG, and at the first cystoscopy patient is having a T1 high-grade tumor, or patient is having a TA high-grade tumor at 3 months that persists even after for reinduction of BCG or maintenance of BCG, or patient is have a persistence of CIS, or patient is developing a high-grade tumor during maintenance. And BCG relapsing tumor is patient has completed his BCG induction and maintenance and has shown initial response to BCG, but again has developed a high-grade recurrence. And now there is a consensus on BCG unresponsive disease. It includes all the BCG refractory disease and also patients who relapsed after maintenance therapy very early. That is, patient has completed his maintenance therapy, but he relapsed within 6 months of completion of BCG. These all patients come under BCG unresponsive NMIBC. Now, what is the treatment of BCG unresponsive NMIBC? Patients with BCG unresponsive disease are not going to get better with further course of BCG. And according to the EAU guidelines, the radical cystectomy is the standard of care, and all the bladder preservation studies currently investigational. However, the radical cystectomy is a complex procedure associated with significant morbidity and has very large impact on the quality of life of the patient, and there is still an unmet need of further bladder preservation strategies for patients who are unfit for surgeries, have a poor performance status, and are also not willing for radical surgery. Therefore, various other intravesical therapies aiming at immunological modulation in the bladder and inflammation targeting agent has been tried in BCG failure patients. And one of them is adding BCG interferon alpha to the BCG. And interferon alpha is a glycoprotein which causes angiogenesis invasion, cell cycle blockage, and triggering of the immune response in already BCG triggered cells. And the group, Michael O'Donnell group, have already shown that free survival rate of more than 50% at 2 years using this combination. However, a Cochrane review is failed to give any answer because they have shown that adding interferon has no benefit over a reinduction of BCG, and further prospective large studies are required to validate this combination. Also, people have tried microbacterial Feli cell wall fragments with nucleic acid. That is also a potent stimulator of inflammatory IL-6, IL-12, and Morales and co-workers have already shown that in their study that it has a durable response at 1 year and it is well tolerated, and more than 25% of patients of CIS and more than 60% patients of papillary tumor are able to save their bladder at 1 year of follow-up. However, there is no prospective randomized study was done further in this molecule, and in 2016 FDA denied its approval as a therapy. Now coming a new molecule, that is Vicinium. It is an antibody of epithelial cell adhesion molecule tagged with Pseudomonas endotoxin, and whenever this binds to the epithelial cell membranes of tumor cell, it gets internalized and causes this toxin causes apoptosis of the cancer cells. And a phase 2 trial by Kowalski et al. Have shown good complete response rates of 44%, which persisted up to 16% of patients at 1 year of follow-up. And currently a VISTA trial is undergoing of intravesical Vicinium installation, and the interim results have been shown in the Cancer Bladder Congress recently. The paper is yet to come out, and they have shown that complete response rate of 42% in CIS patients and 68% in papillary tumor patients. Now there is increased use of immune checkpoint inhibitors in both metastatic, neoadjuvant, adjuvant setting, and we have seen that in a BCG pre-treated patient there is increased expression of PD-L1 or PD-1 receptors, and people have used it intravenously. Pembrolizumab have shown good results in NMIBC, BCG unresponsive patients. However, it is associated with significant toxicity. My subsequent talk is by Dr. Atul Batra. He will be touching upon intravenous use of this pembrolizumab. However, we are more interested in doing an intravesical therapy. Only one human study is currently published using intravesical pembrolizumab along with BCG. They were able to recruit only 9 patients due to COVID-19, and they have used it with BCG. But out of 9 patients, 5 patients were progressed to MIBC in their follow-up study. Therefore, immunotherapy is currently in investigation, and a lot of trials are recruiting patients for intravesical these immunotherapies for BCG unresponsive disease. Another important inflammatory targeting agent is IL-15 superagonist. IL-15 superagonist increases the T cell and natural killer cell activity inside the bladder, leads to more cancer deaths. And there is data from Kami et al. Recently published in 171 BCG unresponsive patients have shown a complete response rate of 71%. And due to these results, FDA has given a fast breakthrough therapy for a fast tracking of this therapy for the approval. Further, now people have tried intravesical chemotherapy also in various agents in the setting of BCG unresponsive disease. The most commonly studied agent is gemcitabine, and various trials and various retrospective studies have shown some results. This is a prospective study by Shaw Group, has shown 47% recurrence-free survival at 3 months. However, the recurrence-free survival dropped to 21% at 2 years. And a recent Cochrane review have shown that gemcitabine, although have shown good results, but the durable responses to the gemcitabines are uncommon despite maintenance gemcitabine therapy. And then other well-studied combination is sequential gemcitabine and docetaxel, though only retrospective study. One of the retrospective study by Steenberg et al. Have shown the 2-year recurrence-free survival of 45%, and this therapy was tolerated well. Another article was by Michael O'Donnell group, recently published in Urology Oncology, that BCG unresponsive patients, the 5-year survival, recurrence-free survival rate was 33%. However, both of these studies are retrospective. There are no prospective study to say this therapy still works. Therefore, to conclude, the intravesical therapy part in BCG unresponsive disease have shown some promising results, and some effect in some cases. However, there is no definitive conclusion can be made because there is significant heterogeneity of the data in the literature and significant different type of protocols used for the studies, and there are limited number of patients enrolled in such studies of intravesical therapy. To further enhance the activity of chemotherapy, chemohyperthermia was used, and what hyperthermia does, it causes DNA damage and inhibits the DNA repair, and also increase hypoxia in the tumor, makes it more responsive to the chemotherapy, and also local heat response acts like a fever, it increases the local immune response in the bladder. And most of the series have shown complete response rate of 50% at 1 or even 2 years. However, a recent trial done by Tam and colleague and et al. Have not found any significant difference of using a chemohypothermic MMC versus reinduction of BCG. And further data is required to validate this therapy, especially in BCG unresponsive disease. And also electromotive drug therapy is also not been well validated in BCG unresponsive disease, though it was used in a first line setting. Now, there is a new gene therapy is being explored in intravesical therapy for NMIBC, BCG unresponsive disease. And one of the most important therapy here is a non-replicating recombinant adenovirus vector-based gene. What it is exactly, it has a copy of human interferon 2b gene into the urothelial cell. Whenever this gene, this interferon alpha 2b gene gets internalized into the cancer cell, it leads to tumor regression in these bladder cancer patients. And there is a study by Bourgian et al. Of 151 patients where this therapy was given both in induction and maintenance phase, have shown complete response rate of up to the tune of 53.4%. And also there are 4 other studies also have confirmed the complete response rate of to the tune of 20 to 60% in these trials. And based on these results, this therapy is called Eldestrin, and FDA has given a fast track approval for the breakthrough therapy designation for this Eldestrin, and this therapy is going to be available very soon for use in intravesical therapy. And also another on replication competent oncolytic adenovirus is CG0070. It also targets bladder cancer cells through the retinoblastoma deficient Ds. And whenever this oncolytic virus internalizes into the cancer cell, it causes cancer cell death. And 2 studies in a prospective manner have examined this intravesical therapy and have shown a complete response rate of more than 45% in this therapy group. And also one more gene therapy, it is a plasmic vector having a sequence for diphtheria toxin. Whenever this diphtheria toxin plasmic vector gets internalized into the bladder cancer, it leads to inhibition of protein synthesis in the bladder cancer cell. And there is a good amount of data coming up with this agent have shown good results by Siddhi et al. In their study. Therefore, there are a lot of therapies are coming up, a lot of trials are recruiting patients for immune checkpoint inhibitors and gene therapy for future application can be used for BCG unresponsive disease. To conclude, currently the radical cystectomy is the standard of care for the BCG unresponsive disease. The alternative therapies are still, we have in a search of in alternative therapies, and all the patients who are not fit for surgery or are unwilling to undergo radical surgery should be enrolled into a clinical trial. If a clinical trial is not available in the center, intravesical chemotherapy can be offered in such patients. Thank you.
So we'll move on to the last part of the voting session.
Okay, so we've got 8 statements to vote on here. So I control it. Okay, so statement number 1 BCG re-challenge can be offered for persistent CIS post-induction BCG for patients seeking bladder preservation. And statement 2, forget the patient bit, is BCG re-challenge can be offered for recurrent high-grade non-muscle invasive bladder cancer, so that's CIS and T1 disease, post-BCG therapy for patients seeking bladder preservation. And statement 3, BCG in combination with intravesical chemotherapy, so like the Distasi regime with mitomycin, can be offered for persistent CIS post-induction BCG for patients seeking bladder preservation. Statement 4, BCG in combination with intravesical chemotherapy can be offered for recurrent high-grade non-muscle invasive bladder cancer, that's CIS and T1 disease, post-BCG therapy for patients seeking bladder preservation. And statement 5 is intravesical chemotherapy, and it's dealer's choice here, whichever regime you want to use, can be offered for persistent CIS post-induction BCG for patients seeking bladder preservation. Statement 6, intravesical chemotherapy, again the regime of your choice, can be offered for recurrent high-grade non-muscle invasive bladder cancer post-BCG therapy for patients seeking bladder preservation. And then the last two statements are concerning radiotherapy. So radical radiotherapy can be offered for persistent CIS post-induction BCG for patients seeking bladder preservation. And finally, radical radiotherapy can be offered for recurrent high-grade non-muscle invasive bladder cancer post-BCG therapy for patients seeking bladder preservation.
So with that, we come to the end of this session on superficial bladder cancer. I thank my chairpersons and my faculty for a wonderful session. With this, we hand over the session to the next coordinator, Dr. Saurabh. Special thanks to Dr. Simon as well for the polls.